Anything else, Lori?
No, I'm going to mute you, and then we'll start at 00.
I'm Berks County Commissioner Christian Leinbach, and I want to welcome you to our weekly COVID.
It's not live yet. Hold on.
Okay, it says live.
Oh, okay. Sorry. You're live.
I am live. Okay. There's nothing like live. Well, it's not really television. It's Microsoft Teams. So we're very glad to have everyone on. I'm Berks County Commissioner Christian Leinbach. This week's COVID-19 update, we're focusing on masks, vaccines, social distancing, what works, and what to expect this fall. We have some guests that I'll be announcing and introducing shortly. But before that, I want to give a little bit of background, and I was going to refer to the Department of Health data, but I'm actually going to put Berks County Department of Emergency Services, Brian Gottschall, on the spot and give us the latest data that you have on the positivity rate. And the positivity rate is the percentage of people that are tested that test positive. According to the statewide numbers, the state is at 4.6%. Where is Berks County in the overall testing positivity rate? Brian Gottschall.
Hey, Commissioner, thanks very much. Yes, as you well know, but for the benefit of our audience, we look at these numbers a little bit differently than DOH. DOH kind of compiles these numbers on a weekly basis, and that means that at any given time, there's a little bit of difference in how DOH is reporting it versus how we report it. We report it on a daily basis, but we're using DOH's data, so it's not like there's different data sets out there. And as of today's reporting, our positivity rate smoothed over the last 7 days in Berks County was just under 7%, about 6.95%, which is actually a small improvement over where we were 7 days ago when we were just above 7.5%. And I don't know if our technical group can bring up my screen share or not, but I have a little graph that shows what our data looked like since June 16th, and we can see how that data has trended over that period of time. Not sure if that's going to be possible for them to get that on the screen.
Yes, it's up now.
Okay, great. So on that graph, what you can see is the blue line represents each individual day's reporting of the positivity rate, or what percent of the total tests that are being conducted in Berks County are coming back as positive. And then the brown line that's in there is what's called a 7-day smoothing. So every 7 days, we develop think of it like a 7-day average, if you will. And we can see that, unfortunately, our positivity rate is trending upwards since where we were at the very end of June, the beginning of July, when our numbers were looking as best as they have been since we've been tracking them.
Yeah, and that's important for people to see. This is what I wanted to focus on for my comments, and my message is we are not out of the woods. We have to continue to take this issue very seriously, and that's why we're having the program today. Thank you very much, Brian, for sharing that. We may reference some data later on, but at this time, I'd like to turn the program over to the Vice Chair of our Board of Commissioners, Commissioner Kevin Barnhart.
Thank you, Commissioner Leinbach, and everyone who's joined us today, especially Dr. Baxter, Dr. Powell. I won't take too much time, but each day I'm more amazed at our technology and our IT staff for pulling together these events, as well as coming up with very timely and important information on these weekly meetings. I have a newfound respect for people having to pull programs together and coming up with content. So I think this is going to be a great one with our healthcare professionals. As we've reviewed our community needs assessment surveys, which I'll be discussing in a little more detail tomorrow at our board meeting, one of the huge significant cost drivers, as many would assume, is our healthcare and the extreme cost incurred by our healthcare providers, Reading Health and Penn State St. Joe's. I'll be sharing those numbers with you tomorrow. They did receive some monies from the government, but nearly not enough to cover the losses they experienced. So I'm really looking forward to this program, and especially that things change by the hour as far as information, but I'm really thinking fall, winter, and want to hear about how we plan and go through the fall and winter, since we've gone through the spring and most of the summer, what we have to plan for and prepare everybody for in the future. So thank you for the time that you're going to spend with us this afternoon.
Thank you, Commissioner Barnhart. Commissioner Rivera, you're muted.
Oh, there we go. Thank you, Commissioner Leinbach. I want to first of all thank Dr. Powell and Dr. Baxter for being on this live program here today, bringing their information. As we've mentioned before, we're not through this. It's not done yet. There's still a lot ahead of us yet. As you know, one of the main issues that a lot of families are focusing on right now is what's going to happen next month when school starts. Some school boards have made the decision to start with online only. Others, as of now, such as Schuylkill Valley, have decided to offer both in-school and online. So although there are certain guidelines out there, it is up to the school boards to make those decisions. So I encourage the parents out there. I'm a parent. My daughter is going into high school now. Please, if you have questions, if you have concerns about what's going on in your school district, please reach out to your school board members, the superintendent, but please do so in a respectful way, in a nice way. They're in the middle of all of this as well. They're trying, just as we are, to make the best decisions they can based on the information that they have as well. So just let's remember, we're all in this together. We're all searching for as much information as we can. And the goal of each one of us is to try to make the best decisions that we can based on the situation that we are currently in, understanding that it moves on a daily basis and with the information that we have. So I am also looking forward to the information that Dr. Powell and Dr. Baxter will have to bring us today. Thank you very much.
Thank you very much, Commissioner Rivera. Before I introduce our guests, I want to note that if you're listening today and you have comments or questions, you can use the Q&A function that is on the Microsoft Teams Live application. Just go in, list your name and your municipality, and the question or comment must be germane to our topic today, and that the topic is largely COVID-19 and a number of different issues surrounding that. If you're from the media, you may feel free to ask more than one question. We just ask that you give us your name and the media you represent. As I mentioned and my colleagues mentioned, we have two wonderful guests. Both of these guests are part of the newly formed COVID-19 Health Advisory Panel for the County of Berks. Dr. Michael Baxter is the past chair of the Berks County Medical Society and past chair of the Tower Health Family and Community Medicine, and he is the chair of our COVID-19 Berks County Health Advisory Panel. Joining him today, a member of our Health Advisory Panel, is Dr. Deborah Powell. She is the section chief for infectious diseases and the medical director for infection prevention at the Tower Health Reading Hospital. Dr. Powell has been a frequent spokesperson for Tower on issues related to COVID-19 in the media and during town halls and other events. Welcome, Dr. Baxter. Welcome, Dr. Powell, to our program today. We're going to begin with a question. We have a number of questions that we asked Dr. Powell and Dr. Baxter to address. But before I do that, I'd like to just give each of you an opportunity to share briefly any thoughts or comments you have relative to our community and you as a healthcare professional dealing with the COVID-19 issue. And we'll start with Dr. Baxter. You might be muted, Dr. Baxter. If you're on your phone, hit *6 to unmute. What we're going to do, this is live programming here. I'm going to switch over to Dr. Powell and have our IS department check. Dr. Baxter is actually calling from vacation, and unfortunately he is at a shore location that got hit very hard. They have no power. My understanding is they're running on generators, and he was trying to get in an area of the house where he couldn't hear the generators in the background. So hopefully we'll reconnect with Dr. Baxter, but go ahead, Dr. Powell, if you can just kind of give us an overview, and then we'll go into the questions.
Sure, I thought we'd just start globally. And again, don't remember how big this outbreak has become. We have a pandemic going on with 18 million cases worldwide, with over 700,000 deaths, and 4.7 million cases in the US with 157 deaths, over 5,000 cases in Berks County. And I work predominantly at Reading Hospital, and I was on call 2 weeks ago, and we saw numbers, 9, 10 patients in the hospital at one point. At the lowest point, we're about double that, about 16 patients currently in the hospital and 2 in the ICU. So currently we have a lot of capacity, but our census is high because people are coming back into healthcare. So we're seeing almost maximum capacity at our hospital. If we need to stop doing elective or semi-elective surgeries, we can do that, but we're here for our community. And everyone's doing the best they can, but I have to tell people that even though that we're quote green, we still have to continue with mask wearing, social distancing, and hand hygiene. I can't stress that enough to everyone that I see.
Thank you very much, Dr. Powell. Is Dr. Baxter on yet? Okay, they're working on that. Let's go to the first question. I do want to note we have a number of people also joining us on Facebook and YouTube. If you want to comment or ask a question, you may do that. Just go into the Facebook or YouTube area, give us your name, your municipality, and one of our staff will pull that off and make sure that we get that. Excuse me. First question, as medical professionals, can you tell us if wearing a face covering is important? Can you please explain the scientific findings behind the recommendation to wear a mask, and are there any dangers to wearing a mask? Dr. Powell.
Yeah, I'm happy to take that one. So we have seen that mask wearing prevents oral and nasal droplets from spreading through the air and exposing other people. These droplets can be inhaled into the respiratory tract and contact mucous membranes such as the eyes and the nose. So there have been studies that show that wearing a mask decreases those droplets from sneezing, coughing, speaking, singing, and that way you don't contaminate other people. So you wear your mask to prevent you from contaminating and infecting other people. And regarding risk, there's really, I say, very minimal risk to wearing a mask. So the exception to those would be people who have really severe COPD, that are having problems breathing, that are currently on oxygen. If you can't wear a mask because it decreases your air intake, that is one exception, but the great majority of people can wear a mask safely. And there's really not any reason for people to be worried about carbon dioxide retention, because there's enough air circulating that you get enough air coming into your lungs. Oh.
You're on mute.
Yeah, I was going to say, now he's muted. Christian.
You're still on mute.
So excited.
The
You're
CO2
muted.
issue has come up often. And where's that coming from? I mean, we have people, I've had people that have told me, Commissioner, you've sold us out. masks are dangerous. They will recycle CO2, and obviously we all know carbon dioxide is not healthy. Where's that coming from?
Yeah, I think people are just afraid. So I think that realize that your surgeons, when they operate on people, they wear masks for hours, if not, some of these surgeries can take 8-10 hours a day, and they wear masks for a long period of time under stressful situations. So we've been wearing masks for a long time, and we've used masks for, meningitis prevention, measles, etc. So we, in the healthcare community, realize that masks do work, and they really do help in stopping the spread of this infection. There were a couple of hairdressers that were COVID positive that wore a mask while they were cutting hair, and none of their clientele got COVID. So I think you have to go back to saying we're doing it to protect ourselves and our families and our community.
Absolutely. Dr. Baxter, are you with us now?
I hope so. Can you hear me now?
Yes.
Hey.
Clear.
Well, the key is #6, not *6. So we figured that out. Okay.
Oh, okay.
So,
pound.
Well, I agree certainly with everything Dr. Powell said, the importance of masks. I guess my concern has been that we've been through so much that we've reached some mask fatigue. And I think part of that too was, although I give people in Pennsylvania a lot of credit because we've really done well overall considering what the rest of the country has gone through. But we went from red to orange to green, and maybe there should have been a fourth color in there, because I think once everybody was so anxious to get to green, it was like a reward. It was like a prize. We've come to the green status that we all felt, oh boy, let's try to get back to normal. And some people did that more than they should have. So just to remind everybody that green doesn't mean that we're all clear. It just means that we're more free to go about some of these normal activities, but we still have to do all those things that we talk about: wearing the mask, social distancing, and personal and practice good hygiene.
Excellent. Brian Gottschall from our Department of Emergency Services has a follow-up he would like to ask. Brian.
Thanks, Commissioner. Yeah, Docs, one of the arguments that we hear quite often about why masks are unnecessary or theoretically shouldn't be worn has to do with the correct observation about the viral particle size versus the filtration capability of the mask. And I think it's, of course, based on people's understanding of what the mask is really stopping from getting through. So maybe you could elaborate that on a little bit and help folks to understand that we're not filtering viruses here.
No, we're filtering out secretions. So you want to prevent those from going out into the air. So you wear your mask to prevent your secretions from infecting other people. There are other layers, different kinds of masks that medical professionals wear. So they're taking care of COVID positive patients. They need that filtering ability to filter out those small viral particles. But everyone else, the cloth mask is adequate to contain those secretions so you don't contaminate the people around you.
And that's because the majority of the viral shed is contained in those secretions, right? Not as like free floating viral particles that have to be filtered out of the air.
That is correct. Yeah.
Very good point. Thank you for bringing that up, Brian. Let's go to the next question, and we'll start with Dr. Baxter. Now that we've been in the green phase for more than a month, what other measures should residents be taking to continue to help mitigate the spread of COVID-19 in our community?
Well, as I just said, the fact that we're in a green phase doesn't mean all clear. I want to be sure that everybody understands that this virus is amongst us. Just because our case numbers are down from what they were, the numbers that we talked about earlier still show that there are people in our community turning positive every day. So the virus is still there. We've been able to suppress it to a certain degree by the things that we've done, all the things that we've just talked about. But just because we're in green doesn't mean that we can let down our guard. So especially as you mentioned too, Commissioner, maybe it was Commissioner Rivera, as we head into the fall, schools are going to open, sports activities are going to pick up. We're going to be congregating more because of the colder weather. People will be indoors more. So we're really going to have to be even more vigilant in the coming months than we are right now. So again, all those things that we keep talking about are just so important, and they're going to be even more important as we go forward into the fall.
Thank you. Dr. Powell.
I agree with you, Mike. So again, we flattened the curve, and that was the goal by doing these things appropriately. Social distancing, wearing masks, and washing your hands. It's helped us to keep our numbers low, and that is the goal until we can get a vaccine. Until that happens, we're going to have to continue this.
Absolutely. I'm going to give a question from one of our viewers. This is from Fred Zentgraf Sr., Berkshire Heights. Per Johns Hopkins coronavirus COVID-19 recovery numbers updated August the 3rd, Berks County not available, Pennsylvania not available. The United States was at 2,315,000, global 10,753,000. We are hammered daily with case and death numbers in the local and national media. I would tell you, you're not getting those death numbers from us locally, but I'll continue here. Why aren't recovery numbers reported for Berks County? Surely they are recorded somewhere. And why are these positive perspective numbers not just as widely reported daily? Do the three commissioners agree that these positive numbers should be reported to their constituents? And if so, see to it, please. Thank you. What are your thoughts on the recovery numbers? We hear this on a regular basis. I will note in the early warning dashboard provided by the Pennsylvania Department of Health, recovery numbers are not one of the areas that they're looking at for the early warning dashboard. So we'll start with Dr. Powell. Actually,
Tower Health does actually track our recovery numbers, and we do have some publicly reported information. If that's not on that dashboard, I'll recommend that it be included, because Clint Matthews made that a priority when we set up our dashboard to always report out our recovery rates. So I agree with him.
Yep, thank you very much. And that data is available. We can look at making it more readily available. Dr. Baxter.
Excuse me, I just want to say, I think Mr. Zentgraf makes a very good point there that, we tend to focus on the bad news, which that's just the nature of things. I mean, this is such an important topic, and certainly for especially high-risk individuals, we can't ignore that. But, people do survive this. People do develop a certain amount of immunity. I'm not going to comment too much on that because I think there's a lot of uncertainty about that. Maybe Dr. Powell at some point will want to comment on the immunity status. But, people are recovering from this. We hear about something called herd immunity, which is a kind of public health term that indicates that the entire community reaches a certain point when approximately, and Deb, you fine-tune me, 60, 70% or so of the community have had the virus. The problem with this virus is, and of course we call it the novel coronavirus because nobody's ever come in contact with this before, so nobody has immunity prior to their contact with this virus. But people will develop immunity over time, but it's going to take so much problem in our community, so many people getting infected, so much morbidity, so much death, that we feel that that's not a good way to go with this particular virus. That's why, as we keep saying, and Dr. Powell just mentioned, we have to suppress the virus until we get a safe and effective vaccine.
Sticking with that, before we go to the next question, isn't the issue also the need to spread out the time in which people ultimately contract COVID-19 so that we don't overload our local healthcare system? Isn't that what happened in places like New York City and in particular early on in northern Italy?
Yeah, absolutely. So we're trying to flatten the curve just so we don't have that great influx of patients like they saw in Italy and New York City. And we did a really good job of that in the spring. But I am concerned as time goes by and as the southern states were kind of lax in how they kind of approached COVID, they didn't encourage mask use, that their numbers are really exponentially increasing. And Mississippi right now is really being hit, and they don't have ICU beds. So
the bottom line is a very good question by Fred. And I would ask Brian Gottschall if we can work with Reading Hospital Tower Health and possibly even Penn State Berks and see if those numbers are readily available on recovery so that we are not always highlighting the bad news. The third question that we have, are there any new developments you can tell us about with COVID-19? Any new symptoms? Specifically, what is a super spreader, and what are your thoughts on recent studies about children being super spreaders?
I'm going to defer that to Dr. Powell. Deb?
No, I'm happy to take that one. So what we've seen so far about new developments is we have more and more data now regarding what works and what doesn't work. So what appears to be working now for severe disease, moderate to severe disease, is steroids and remdesivir. Otherwise, for milder symptoms, it's supportive care. Some of the initial thoughts we had regarding hydroxychloroquine and even a drug called tocilizumab that kind of suppresses the immune system really haven't shown any positive effects, and some side effects that are not worth the risk of getting those medications to people. So we have some better information about treatment. And super spreaders are, well, I guess I'll go on about new symptoms. So basically the triad that we usually thought of was fever, shortness of breath, and cough, but people can also have other symptoms. Some people have very mild symptoms and no symptoms. And some others have GI symptoms, headache, myalgias where you just ache all over, arthralgias where your joint hurts. So there's other things that can happen to patients that aren't what we consider typical symptoms. And then the super spreader discussion is these people can have high viral loads and can infect a lot of people around them. There was a choral group in Washington State where almost the entire chorus got infected. They had a 2.5-hour choir practice with 61 people, and 52 of them got infected. So again, you can have people in a close proximity and in an enclosed space that can get a lot of people around them infected. So we've seen super spreaders in other situations such as tuberculosis, and even typhoid Mary was considered a super spreader, and she spread salmonella. So, and then children can have very mild symptoms, and again, they can have high viral loads. So I'm not surprised that children can also be super spreaders.
So, and typhoid Mary, wasn't she largely asymptomatic? Wasn't that one of the issues?
Yep, and she made food. She was a cook in the New York City area, and she made food for different wealthy families, and once they got sick, she moved on and cooked for other people until they finally arrested her, and then they had to take her out of circulation. Yeah.
So what kind of a risk is there from asymptomatic people and COVID-19? I've heard arguments from healthcare professionals both ways.
Yeah, I think they are at risk of spreading it, so that's why we all wear a mask, because you don't know who's infected. And just because your friends and family feel fine, it doesn't mean that they may not be infected. So I would recommend you wear a mask when you're around people who are not in your immediate family, in your immediate household.
Very good.
I would agree. It would be much easier if we could just stay away from sick people, right? Because that makes a lot of common sense to everybody.
Yeah.
But unfortunately, with asymptomatic carriers, we can't be too careful, and that's where the masks, in particular, play a big role.
Yeah, and I want to encourage, my colleagues are on the call, Brian Gottschall from DES. If you have follow-up questions similar to what Brian did earlier, just jump right in and ask your question.
I actually do. Relative to the mask issue, any better or worse mask? What's the best mask? What's the most acceptable mask out there? I've heard about handkerchiefs aren't as effective as a surgical mask. A surgical mask is better than a cloth mask. Which one is the ideal? Except for N95s, because that actually has to be fit tested, and people really shouldn't be wearing an N95 unless they've been fit tested for it. Maybe you can guide people on the proper mask to wear when they're out.
Yeah, I would say cloth masks are adequate for everyone to wear when they're out in public. If you're in a healthcare situation taking care of potentially infected patients, then we step it up to a surgical mask. And if you know that they have COVID-19, we wear an N95.
Okay.
I've worn an N95 for hours at a time, and it's a hard mask to breathe through. So I would not recommend that the normal population wear these on a continuous basis. And also, we need to preserve that supply for our healthcare workers. So a cloth mask, even a homemade mask, is adequate. People can use handkerchiefs, whatever, because again, it's a physical barrier keeping the secretions from becoming airborne.
And
Very
Brian,
good point.
let me just say.
Very good point, Dr. Baxter.
Yeah.
We have Brian Gottschall wants to go back to the recovery question. And since it's still pretty fresh, I'm going to turn it over to Brian for a follow-up.
Thanks, Commissioner. I appreciate that. I wasn't intending to derail us, but I wanted to make sure that we mention that part of the concern, and I would look to the docs to correct me or support this position or my assertion, is that there isn't a clear definition of what recovered means. There's become a generally accepted definition of recovered means that you didn't become deceased and that you're 30 days past your positive test. And I wanted to point out that while we don't talk about those numbers at the county level because we don't have that information, the Commonwealth of Pennsylvania does. And on the Commonwealth dashboard, they do clearly indicate that 76% of the identified cases, and this is current as of today, are in fact recovered cases because they have access to PA-NEDS, which is the infectious disease database where all of this testing is reported. They're able to see when somebody tested positive and that they subsequently didn't become deceased in those 30 days, and then assume that that person is now recovered and report that as a recovered stat. In an effort to protect folks' privacy, that level of information isn't made available to us at the county level, and that's why we really can't boil it down to, in Berks County, how many cases are recovered. We know that on some given day there were 600 tests given and that 30 of those tests came back positive, but what we don't know is ultimately what happened to those 30 people out 30 days later. I just thought that was an important
point
to give. It's not that anybody's covering anything up. It's just that varying levels of government have different levels of access to the data. And I would argue that at the state level where they have the access, they are reporting that.
Any follow-up to that, Dr. Powell or Dr. Baxter?
Yeah, I know that Tower Health has similar data. I was going to guess about 76% the last time I looked at it. And we can provide that to people who want to know that information.
Thank you very much.
I think Dr. Powell would be the first to say that since this is really her field, and we've said this before, that there's just so much to learn about this, as we call it, this novel coronavirus. And there will be much, much, much further study and much written about this in the months and years to come. There's just still so much we don't know.
And that brings up an interesting point. Is part of the problem that some of the professionals and definitely some of the politicians are acting like they have all the answers, when in reality, we're learning as we go about this virus, and we don't have all the answers. Is that a fair thing to say from a professional standpoint? Dr. Powell.
Yeah, I think it's a very fair thing to say. And honestly, when this started back in March, we were treating people based on our best information we had at the time, and we've learned things as we go. And that's not a very comfortable way to be in medicine. Again, we try to do evidence-based practice where we've tried things, we know that they work, and we don't experiment on our patients, but there were a lot of studies that we enrolled patients in for us to learn more about these treatment options as time goes by. It's very unnerving, and we're all doing the best we can.
And Commissioner, I've been in medicine a long time, even longer than Dr. Powell, certainly. But there were things that I thought I knew for sure 30 years ago that I realized that I didn't. And good doctors, and I know Dr. Powell is one of these, I don't think ever draw the line in the sand and say, I know all the answers and you don't. We present the best scientific evidence, the best public health information that's available at the moment, and that will invariably change. There's very few things that I've seen in medicine from time to over time that hasn't changed. So there's nothing set in stone. We just make our assumptions and give the best advice we can based on the evidence we have.
Yeah, and I'll just chime in with that too. So back early in the pandemic, back in March, we had treatment guidelines we gave out to the health system. And honestly, about every 2 weeks, we were readdressing what is new in the literature, what's actually proven to work, and we've been making modifications. And this document is evolving, and it's a living document. And we have pulmonary critical care, infectious diseases, the hospital service, and pharmacy helping us develop these guidelines.
Yeah, very good points. Next question. Now that we know COVID-19 is not going away soon and flu season is quickly approaching, how do we chart these waters this fall? Are there signs of a predominant flu coming in? Do you have any recommendations for residents to protect themselves from the flu and reduce the chance of getting hit by both the flu and COVID-19?
Dr. Powell, I'll give you first crack at this.
Okay, thank you. I guess the first thing I would say is take the last question first. So I recommend everyone get the flu shot early in the fall. So get your flu shot. They really, really do help. And what we do is when we make up the flu shot, we look at circulating strains, and we do it about a year in advance. By February of this year, they're already making the vaccine for this fall because you have to have time to make it. So they changed the formulation that was in last year's vaccine to this year's vaccine, and you can either get a 3-virus vaccine or a 4-virus vaccine, and it's the best prediction of what viruses are going to be circulating this fall and winter.
Very good.
And let me just say that if I was an emergency room doctor, I think at this point, what would begin to keep me up at night would be worrying about a bad influenza epidemic this fall on top of the COVID-19. So you see a sick patient with cough, shortness of breath, high fever. Do they have COVID? Do they have influenza? Do they have both? Do they have neither? That would be, and we're going to see these, and if it's a bad influenza season, we're going to see a lot of these. So Dr. Powell is certainly right. Unfortunately, we can quickly test, or relatively quickly test for influenza. But still, as we will find out, there's nothing that says you can't have influenza and COVID, or you can't have influenza and develop COVID. So the best thing to do is get your flu vaccine and do all the same things that we've been talking about for COVID that will also protect you from influenza.
So 2 points following up on that. One, both of you mentioned the flu vaccine. I know from my doctor that he had recommended don't get it before early October. Is there any more appropriate time than another time to get the flu vaccine relative to overall effectiveness?
Guess I'll take that one too. So I would think September, October is appropriate. You want to get it at least 2 weeks before flu starts circulating. Usually we see flu in November through December and January, so I wouldn't wait too long, but I think October, September timeframe is fine.
Excellent. The second question, Dr. Baxter, you really alluded to this. I believe the fear that Dr. Fauci talked about, it's probably a month and a half ago, with flu season and COVID wasn't, as some journalists reported, that somehow COVID was going to be worse, but the overlapping. And we saw this year in, I believe it was, I don't believe, I know because I ended up in the hospital, January and early February, our hospitals got slammed with the flu. You could go into the ERs and they were packed and it was difficult getting a bed. We didn't have the first COVID case until in Berks, I believe till March the 6th. Isn't a real serious concern the overlapping and the taking up of the resources of COVID and the flu?
Well, I'm glad you mentioned that back in January. And again, Dr. Powell can add her comments here. But I think when they looked back at some of the quote flu deaths that occurred, particularly in long-term care facilities, nursing homes, we always see those, and a certain percentage of older nursing home patients contract the influenza and don't survive that. That happens every year. And I think that we now know that some of those influenza cases probably or may have been COVID cases, because as we've been talking, there's such an overlap between the two. And before everybody really understood COVID as we do now, it was very easy to assume it was the typical influenza. So it's going to be a difficult thing. Now, again, thank goodness we do have some pretty good tests for influenza that will help us sort that out. But there's going to be a lot of overlap. There's going to be a lot of confusion. And most importantly, there's going to be a lot of patients with potentially both that could fill up our ERs and fill up our ICUs and our ventilator beds.
Thank you, Dr. Powell.
Yeah, I'm just going to chime in regarding the testing piece. There are some combined tests that include both flu, RSV, and COVID that will be coming out hopefully very soon, that we'll be able to do all 4 tests at one time. And that'd be very, very helpful for us to figure this out. But you're absolutely right. So that is our fear. Again, we're going to see an uptick in COVID at the time that the flu season starts, and we'll see a lot of volume.
Well, thank you.
I have a, Commissioner Einbach, I'm sorry, I have a question.
Yeah,
here.
Go ahead, Michael. Yeah. Commissioner.
So my question is, I've spoken with a few people that have said, well, back in November, December, January, I had COVID symptoms. So I think I had COVID even before they knew it was COVID. Is that a fact, or do we know that it started here in March, or could someone maybe have gone in with COVID in November, December, January, and we didn't know what it was?
And Deb, this is a good time to comment on antibodies.
Yeah, I would recommend that patient or that person be tested for the COVID antibody. So we have now good antibody tests that people can look to see if they have an antibody to it. I think that back in November, December, probably not COVID, but early in February, depending on what the exposures they would have had and if they were traveling, possibly. So I've had a lot of providers ask me about antibody testing, and if it's positive, it's most likely related to a COVID infection, but just to warn people that you can get some false positives for common coronaviruses that cause the common cold, and you can get false negatives too. So It's not 100% either way, but it would give that person more information, which would probably be very valuable.
Okay, and a follow-up question to that. I've heard that there could be, or there are different strands of COVID. So even though I got it once and I have the antibody, it doesn't mean that I couldn't get it again.
Yeah,
how true is that, or?
Yeah, that's a really good question. So it's not clear at this point if those antibodies are protective and how long they last. So even if you have a positive antibody, I would tell people to continue wearing a mask because we don't know. So some initial studies think that the antibody is protective, and that you are right, there are more than one strain circulating, but they're close enough right now, we believe the antibody is protective. But if it continues to mutate, and these viruses mutate, that the antibody you have this year may not protect you against next year's strain, because that's what we see with the flu, and that's why you need to have the flu shot every year. Really good questions.
Yeah, great question, Commissioner Rivera. We have a question from Karen Shuey from the Reading Eagle, and this is a very good one. There have been reports that many are struggling to overcome a range of troubling residual symptoms months after they are considered recovered from the virus. Is Tower Health seeing this here in Berks County?
I would say yes, that patients may take a while to recover. And even healthy young people, even weeks after they're supposedly recovered, may still not be back to their normal level of activity because they just feel that rundown. So I think people will have some residual symptoms. If you ever had a bad case of the flu, you don't feel good for weeks afterwards. And I think COVID is going to be very similar to that.
Dr. Baxter?
Oh, I would agree again, and I don't want to keep falling back on that, but there's just so much that we're still learning every day, every week about this novel coronavirus. But as Dr. Powell said, it certainly seems like for some people, well, we know some people get hit, of course, a lot harder than other people, and some people seem to carry the symptoms a lot longer than other people. So that's kind of the situation we're in, and we're going to learn more and more about this.
Follow up by Chuck Brantman from, we're going to call it Reading, Pennsylvania. Chuck is one of our IS staff, and I don't know exactly where what municipality he's from. He says, do we know anything about even longer term residual effects, such as neurological issues we all may have read about? And I've read some of those claims. Is that fact, fiction, or are we still trying to figure it out?
Yeah, realize that some of the really severe cases of COVID had like clotting issues. So you could actually get clots all over the body, you know, small vessels in your hands and feet. Some people lost limbs. They had strokes related to COVID. So it depends on how severe the disease was in those patients and what residual effects they will have afterwards. It's a huge problem. And this is more severe than what we see with the influenza virus. So, and there's so many different manifestations of this, and who it attacks so severely, you know, young, old, it really is a virus we're learning a lot about.
So first of all, I have a note here from Brian Gottschall. First case in Berks County confirmed was March the 18th. Back to just what you said, when you look at the effects, one of the things we still are hearing from people is the flu. It's just like the flu. We know from healthcare professionals it's not. How is it different, and why is it more serious than, I'm not going to assume, is it more serious than the flu?
I would say it's much more serious than the flu. Just the death tally alone is much more serious than the flu. But we didn't see the hypercoagulable state where people actually had stroke symptoms, heart attacks, you know, thrombosis in vessels. We don't see that with the influenza virus. And I heard that early on. People were sending me Facebook messages going, oh, it's like the flu. And I said, this is going to be much worse than the flu. And it has panned out to be that way.
Yeah, in spite of the efforts we've taken to flatten the curve, if we hadn't, things could be much worse. Dr. Baxter.
For COVID, that things could be things could always be much worse. Of course, now as I think we've seen, we got hit pretty hard in this country with the number of cases compared to, many other parts of the world. But yes, I mean, we saw in many states, New York, Pennsylvania, New Jersey, that through all the things we just talking about, at a time when cases were just increasing exponentially, that we were able to flatten the curve. So had we not done that, there's no telling how many cases we would have had.
Right.
Unfortunately, we've seen this occur in some other parts of the country, and now they're making their efforts to flatten the curve. So that's why we keep going back to how important it is, since there's no actual treatment for COVID-19, that we do these interventions that we keep talking about.
So let's move on to the issue of a vaccine. What are the benchmarks that must be reached in order to have a viable vaccine? Do you have any updates about a vaccine? And I'm going to add to that, there are people out there that are saying, don't take the vaccine. It's the first round. You don't want to be in the first group. There are people out there claiming that the vaccine is going to be mandated, that it's going to have electronic tracers. There's a lot of debate around the vaccine. So if you could talk about where you believe we are in getting a viable vaccine, and then some of the challenges that are being widely circulated against the vaccine. And we'll go to Dr. Powell. I'm guessing this is more in your line.
Yeah, I'm happy to take this one too. So right now there are about 165 vaccines that are being developed, and there's 27 in human trials, and right now we have 6 in phase 3 trials. That's good. So it has to go through several phases in order for it to become approved. So phase 1 is a safety and dosage study. Usually these are done in small numbers of patients. And then you go to phase 2 where you have expanded safety trials where you have hundreds of people. And then the phase 3 is where you have large scale efficacy trials. And that's what we're doing right now. And there's 6. And I've heard of 3 of these in the marketplace. Moderna got on board early and they started their phase 3. Pfizer is in a BioNTech, they're in a phase 2-3 combined study, and then AstraZeneca is part of an Oxford study. So those are all the ones that I've heard here in this country, and there are a couple other ones that are abroad. So our hope is maybe within 6 months we may have a vaccine that's going to be, efficacious, and that's what we're all hoping for, and safe. But we won't be able to kind of stem the wave that we're running until we get this vaccine approved and disseminated. So I guess my concern is once they have it available, how is it distributed and who gets it first? And again, I would say the highest risk people should get it first, maybe the frontline providers. So you can't vaccinate everybody at the same time. So we'll have to figure out a staged approach on how to get the vaccine out to the public.
So what about the claims being circulated about the dangers? And I understand some of this is coming from the anti-vax movement. Yeah. But some of it is in the more general population.
Well, this is a kind of a rush to get a vaccine out there. So I understand people saying, are we doing it too fast? But by not pursuing this aggressively, we're going to have more and more people die. So I think it's all risk and benefit. I think getting a vaccine to the population is going to be key to prevent deaths. And Mike was talking about herd immunity, Dr. Baxter. So you're going to need probably at least 80% of people being immune. And right now we're about 5% of our community being immune. We have a long way to go. And all we can do between now and the time the vaccine comes out is to flatten the curve and try to prevent people from being infected.
Dr. Baxter.
Well, I share some concerns. I know Dr. Powell, many of us have heard and she's lived it, the story of vaccines. It's taken vaccines, anywhere from probably 5 to 10 years sometimes for vaccines to be developed. And this one, it seems like, is being developed in about 9 to 12 months. So I think there's going to, and again, as Dr. Powell said, it's a matter of risk benefit. But I think there's going to need to be some, and plus we have politics mixed into it this year. It's an election year. That there's going to need to be some strong evidence put out there that this is truly, whichever vaccines come to the fore first, that they are truly safe and they are truly effective, at least to the standards that we usually recommend.
I'm going to actually ask a question. Normally, we require name and municipality, but this is a good question, so officially I'll ask it. Is testing for COVID-19 right now only for those with symptoms, or are people like healthcare workers tested regularly to protect their patients? Partially, I will answer. The Berks Nursing Home through Pennsylvania DOH and CDC has been in a weekly testing of residents and staff for just that reason. So there's a special testing program in place, I know, for nursing homes. But beyond that, do you still need to have symptoms in order to be tested, or are there other types of testing taking place for asymptomatic people?
And I think I'll take that one too. So we're testing symptomatic people. We're also testing nursing home patients before they go back to the nursing home to make sure they remain negative while they're in the hospital. We're testing some preoperative patients who are at high risk for surgery to make sure that they're negative prior to surgery. But we don't have the ability to test every employee weekly. Realize that Tower Health has like 14,000 employees. And our initial testing allotment that we got has increased, but I have the limit of about 1,000 tests a week to test for all 7 hospitals, for all symptomatic patients, and everybody else is sent out to a reference laboratory for all the outpatients, and that result is taking about 7 days. So again, it's not timely enough to exclude people from work. So testing is my biggest challenge every day, getting enough testing and trying to get more testing to test more of our inpatient and outpatients.
So let's stick on testing, because I know through Brian Gottschall that testing kits, as you noted, are still in limited supply. The reagent aspect where the tests are done or executed, and the time. We're hearing some of these tests, in some cases, taking more than 2 weeks to get them back, which can cause real issues. Where are we, Dr. Powell and Dr. Baxter, in the testing challenge, and what's driving that? Is it primarily the production is largely from overseas for these kits, or is it other issues?
I think it's much broader than that. So when you're talking about testing kits, are you talking about the sampling devices, the swabs and media? That's only one part of it.
Swabs to media, and then all of that.
Yeah, that's only the collection part, but then we also have the supply chain regarding even plastic pipette tips were back ordered. The little trays of the test itself is done in, were back ordered. So it's all supply chain. We've had instruments ordered for months. We're supposed to get them in August. The Roche platform, 2 big machines that could run 2,000 tests a week for me. They're being back ordered into the later fall. So I'm ordering different machines, but it's never clear how soon you're going to get these devices. And now the entire country's ordering them, so they may be taken by the federal government. They may be put into the high hotbed areas. So it is a challenge. We can order a lot of supplies. We don't always get them. Our supply of COVID testing tests last week for the Panther platform was not sent to us. So we're at the mercy of our suppliers on how much we can actually procure. And it's quite a challenge.
Commissioner, if we can build on that a little bit.
Sure.
And again, please, I would
And
ask.
this is Brian Gottschall, our head of DES.
Thanks, Commissioner. Yeah, again, I would ask the docs to dovetail in here and kind of maybe elaborate on where I don't really have the education and background. But we had an event a few weeks ago with a community figure, another Facebook Live event, and we discussed testing a little bit. And the moderator said, well, it sounds like you're anti-testing, Brian. Why do you think people shouldn't just go and get tested because they want to? And I made the point that it's not that I'm anti-testing, I'm very pro-testing, but I'm pro-testing of the right people who need to have the testing for the right reasons because of the limitations in the supplies that you're noting. And maybe you could elaborate a little bit more on why John Q. Citizen simply going and consuming one of those very short sampling kits and then ultimately the reagent kit at the laboratory, taking the time in the laboratory machine to process that test when really that person didn't have any driving need to be tested, why that's a concern in a bigger picture community impact.
Yeah. So realize that, John Q. public without symptoms gets tested. I don't prioritize them to our in-house test. So they're going to go out to our reference laboratory, and then they're getting tests from all over the country. So Quest currently has such a backlog, they're pooling 10 specimens into one specimen to run 10 times that amount just to get the throughput they need for the machinery. So again, they're just getting inundated by testing. So when we say we have adequate testing, it's hard to say that we have enough rapid testing. And if it's going to take you 10 days to get a result back, in 10 days, you're over your disease. So we're testing symptomatic people as a priority. Asymptomatic people kind of get further down in the queue.
And Dr. Powell, would I be correct in saying that someone in the community who thinks they should be able to go get tested just because they're a little worried, they don't have a known exposure, they don't have symptoms, they just want to kind of know whether they have COVID, that person really, at the point in time that they produce in testing, shouldn't they be prepared to self-isolate for the duration of the time that they're waiting for their test, or else there's really there's no point in getting the test. They're clearly being tested because they think for some reason they're COVID positive.
That's absolutely true. So that's what is recommended. So the moment you get the swab until the result comes back, you're recommended you quarantine at home. So you should isolate until the result is returned.
Excellent point. Any other questions? We've finished the questions that we had prepared, and before I give our guests an opportunity for closing comments, open it up to anyone else in our Teams group, the other commissioners, for comments or questions. Okay, I'm going to start with Dr. Baxter. If you would share some closing comments, and then we'll go to Dr. Powell for her closing comments.
Well, I'd like to thank the commissioners and commend the commissioners for the importance that they put on this issue. I know this is one of several events that you've held, and certainly the medical community appreciates what you're doing. Hopefully the community at large, because it is such an important issue. I want to remind everybody that we have no treatment for this disease, that the only way we can, as we say, flatten the curve, suppress the virus in the community is through the things that we continuously recommend, which is the mask that we talked about today. And I know the question came up, what's the best mask? To me, the best mask is the one that you're willing to wear. Any mask is probably better than no mask. I think it's more important probably how you wear the mask. And of course, it should cover the nose, cover the entire face, chin, and be, fairly tight at the same time. Social distance. It's such a temptation, especially in the summertime, to go out and, get together with friends and socialize. But, we have to be very careful about that. Hand washing. And then my last point is what we talked about is the concern about what's going to happen this fall, that we can't let our guard down, because this fall is going to be, heading into winter, is going to be a very crucial time for all of us, with schools, with activities, with more indoor socializing. remembering that the virus is not gone, it is out there amongst us, and we've got to be vigilant to keep the virus suppressed until we have good treatment and a safe and effective vaccine.
Thank you very much, Dr. Baxter. Dr. Powell, your closing thoughts.
Yeah, I totally agree with Dr. Baxter. So we need to continue to socially distance, wear our masks when we're out in public, and hand hygiene. I'd also put a plug in here for contact tracing. So Cook County Wellness is doing this for our county. If they contact anyone, please participate and give them the information that they require. And to recommend that everyone get the flu shot this fall, just to prevent you from getting the flu. So thank you.
Thank you very much, Dr. Baxter, Dr. Powell. I want to also not just thank you for being on the program today, but for volunteering to assist the county commissioners on the COVID-19 issue through the COVID-19 Berks County Health Advisory Panel. Dr. Baxter as the chair of that group, and Dr. Powell as a very important member of that group. A couple things in closing. Number one, I want to highlight how proud I am of my commissioner colleagues, Commissioner Barnhart, Commissioner Rivera. From day one, we made a commitment to deal with this issue based on the facts we know, and to be very honest with people that there's a lot that we don't know, and to work throughout this effort to drop the politics and focus on the science. Today's program is part of that effort, and we've fought to not make it political, and it shouldn't be. I want to encourage the people that are listening. A lot of what you heard today, yes, is science, but it also is common sense. Listening and understanding that the virus attaches to droplets and that a mask limits those droplets. I'm going to give an example that Brian Gottschall gave me a while ago that helps understand. If somebody walked up to you and said, I'm going to spit in your face, but I'm going to give you a choice. I can do it wearing a mask, a cloth mask, or without a cloth mask. I would ask you, what would your choice be? I know what I would choose. I would say, let's go with the cloth mask. And why would you choose that? Because we know that a significant amount, if not most, of the aerosol would be stopped by the cloth mask. But there's a bigger issue here. We need to do what we do, not because life is about me, but because life in Berks County should be about our neighbor. Love your neighbor. A very simple and very true commandment, if you will, to love your neighbor. And that's what this is really about. Maybe you're not worried about getting COVID. You think you're going to be fine, but the people around you, many are very concerned, and I believe legitimately concerned. Let's show respect. Respect in the way we treat others by wearing a mask, by social distancing. But let's show respect on how we respond to others in social media, and how we respond verbally. We don't have to always agree, but let's do the right thing for other people in our community. Thank you again for joining us. I again thank my colleagues for continuing to work to provide good information. And again, thank you, Dr. Powell. Thank you, Dr. Baxter. And hopefully you'll join us on our next weekly update. Stephanie Weaver, our public relations officer, will be getting information out when and what the topic will be on our next weekly update. Thank you.